Okay, welcome everybody to our rounds, February the 24th. We are very lucky today. We have Dr. Michelle Gordon with us from Aurelia Soldiers Memorial. She is graduated from medical school at the University of Toronto and completed residency and additional training in neonatal, sorry, I'm going to mutilate that.
Baby medicine.
At the Hospital for Sick Children in Toronto. She is a pediatrician in Aurelia and is also the clinical director for Children's Complex Care Clinic and Neonatal Follow-Up in Aurelia. Welcome.
Thanks very much, Kathy. Do you want me to go ahead and get started and people will just join as they come?
Yes, please.
Okay, sounds good. So hello, everybody. There's a few familiar names there. I'm just going to see if I can start this as a slideshow. There we go. Can I just get a thumbs up from people? Can you guys see that as a slideshow now? Okay, perfect. If my camera starts to go bananas, just let me know. So today we're going to talk about SSRIs, marijuana, and opiates in pregnancy. What do we do with the baby? So this was actually a request from you guys. After I did rounds last year. And so we're going to spend some time talking about what we do. And I chose these three. The request was really around opiates in pregnancy, and I expanded it to include SSRIs and marijuana, because those are really common exposures that we see. And there's often questions about what do we do? Yes, I'm very happy to be interrupted with questions. And as any of you who've done rounds with me before, you know that I'm going to pick on people when we get to questions. Okay, let's see if I can. Okay, there we go. I do not have any relationship with for-profit or not-for-profit things. There's no conflict of interest, and have received a speaker honorarium from the Parry Sound Education Group. So we're going to talk about, and I do apologize, I see that my screen's gone funky again. I'm not sure if I can prevent that for you guys. We're going to talk about common substances that impact neonates at delivery. We're going to talk about SSRIs, marijuana, and opiates. We're then going to spend some time talking about the new neonatal abstinence syndrome treatment that's coming down the pipeline. We expect at Soldiers that we're going to be implementing this in the next month or two. And so we'll talk to you guys about what that looks like, what the families will be experiencing, and because it's very helpful when you guys are preparing families to come down to us for this. And then finally, I'm going to try and give you guys a really practical primary care checklist around what do we do antenatally, intrapartum and postnatally when we've got moms and babes who are exposed to any of these medications and substances. So we're going to start first with a case. So these are all real but de-identified cases. So this is a 32-year-old G3P2 mom. She'd had a normal pregnancy, a normal ultrasound. She was GBS negative. Her serology was protective. And she's taking sertraline 150 milligrams once daily. She went into labor spontaneously at term and had quite a precipitous delivery. So this is a true story. I was relatively newer in my career, was on call for the weekend, had planned to go home because I was done everything I needed to do, and happened to walk by obstetrics and saw this woman in labor in the hallway. She actually was somebody I knew. And just said, oh, hey, congratulations, you're having a baby today. And the nurse just said, do you mind sticking around for a little bit? We just have a feeling. And I'm like, no problem. There had been some variable D cells prior to delivery, and then the baby came out very, very precipitously, fortunately with me standing in the hallway just before the baby came out. So what are your concerns and what are your plans for delivery? I'm going to pick on people by name unless you guys volunteer. You guys can either put stuff into the chat if you like, or just unmute. I see we're a small but mighty crew today. Dr. Power and Kelly Hurry, I know who Tim is. Are you guys family docs, nursing staff? I don't know who you are and what your background is. So I can pick on you guys.
So I will tell you that John is a physiotherapist.
Okay. But
And then I'm not sure if Kelly is actually signed in, but it's Dr. Twin.
oh, Dr. Thwin, okay.
So we
Okay.
might have two.
So we won't harass John because I wouldn't know. So Tim or Noreen, do either of you guys want to make any comments about your concerns or plan for delivery with this baby?
The concerns would be that I am there and you're asking me to plan for the delivery. So I think that the biggest concern was the one that you sort of identified, was that the nurses said to you, who are in the midst of this and know the woman well and what's going on, that something just doesn't seem right. Can you stick around? And then I guess some of the, if I go back to the other slide, I have to look at it again there, but some of the D cells and things like that, that they're noticing that they sort of picked up on. And then, yes, hopefully someone like you or one of our OB providers are on their way in.
Perfect. Okay. So
I mean, obviously the medication as well, but to me, first off, it's not what I would be concerned about or even thinking about, to be honest.
okay.
Right, like the sertraline, right? Like it's not, to me, to be honest, right? It's not like, oh, ooh, this is a big sort of high risk thing, the way I understand and know OB, but obviously to you regular providers, it may mean something different.
Perfect.
And for today's talk.
Yeah, so that's one of the things we're going to talk about. Okay, anybody else want to make any comments, or we'll continue on? I'm going to pick on you a lot today, Tim, I think. So baby was born flat and cyanotic at delivery and had no respiratory effort. As I said, I was in house at the time. They called me overhead and I arrived at about 1 minute of age. And we started bag valve mask ventilation. The chest really was not moving well. Oxygen saturation, in spite of bag valve mask ventilation on 100% oxygen, was 50%. And the APGARs were 2, 4, and 8. We intubated the baby at 3 minutes of age, and with that got improvement in the chest movement and the oxygen saturation. So we go through by systems. The baby was intubated. Baby was then on the ventilator and had good air entry with a rate of 40, pressures of 20 on 5. And the FiO2 was 100%, which is what was needed to keep the SAT above 90%. The baby did not have a murmur. And from a neurologic point of view, D for disability, the tone was improved by about 10 minutes and the glucose was normal. We confirmed that the tube was in the right place, did a chest x-ray, inserted UA and UV lines, covered the baby for infection, and then transferred the baby to the hospital for sick children. So at Sick Kids, this child improved with ventilation, did not end up requiring nitric oxide or oscillation, which are kind of the next things that we would do for a baby with pulmonary hypertension. The baby had an echocardiogram to make sure there wasn't an underlying cardiac issue, and that was normal. And the diagnosis ultimately was persistent pulmonary hypertension of the newborn, likely secondary to SSRIs. And this child was discharged home, neurologically normal, and has gone on to do very, very well. It's actually off at university now. So if we talk about SSRI use in pregnancy, SSRIs in general are very common because mood disorders are really common. So the annual prevalence of depression is about 4.7%, and the lifetime prevalence for anybody is about 11%. And women are twice as likely to be affected than men. If you include minor depression, you'll see that about 19% of people at any time will experience that, and about 70% of pregnant women will report some depressive symptoms. Anxiety is also very common, affecting somewhere between 15 and 25% of the population. And perinatal and postpartum depression is very common, affecting just under 10% or 7.5% of the population. And so mood disorders are really common. So the question then becomes, what happens if we don't treat depression and mood disorders? And untreated mood disorders do have significant impact on moms and babes and on the outcomes. So we know that untreated depression will affect the pregnancy because moms are more likely to have poor nutrition. They're more likely to continue with smoking and substance use. And for babies who have been born to moms with untreated mood disorders, they're more likely to be small, they're more likely to be premature, and they're less likely to be breastfed, all of which are going to have a longer term developmental impact on these kiddos. We also know that from a longer term point of view, from an infant development point of view, moms with untreated depression will have lower quality maternal-child interactions and higher rates of, and the children have higher rates of emotional, behavioral, and academic performance difficulties as they get to school age. So untreated depression, untreated mood disorders are not benign. We then talk about congenital malformations with SSRIs. This is really controversial. So in the past, there's been discussion around paroxetine causing anencephaly or cardiac issues, fluoxetine causing craniosynostosis and cardiac issues. So these are some of the concerns that were raised. And there was a European study that suggested that perhaps SSRIs were associated with anorectal malformations, gastroschisis, renal dysplasia, and cardiac issues. So we had to turn to our Nordic colleagues. I love the Scandinavian research, not the least of which is because my daughter's in Norway right now. But they did a Nordic study. They're in the Scandinavian countries. They actually register everybody and then they attach it to their health data. And so they're able to do these beautiful, large, longitudinal studies. And what they found in the Scandinavian countries is that there was no increased risk of congenital malformations. They looked at the population as a whole, whether they were on or not on SSRIs. So it's a bit of a dog's breakfast. Some studies will demonstrate an association in congenital malformations and others do not. There is no increase in neonatal deaths or stillbirth. Systematic reviews show possible link with preterm births and lower birth weight, but a population-based cohort study shows that SSRIs actually decrease preterm birth and cesarean section rates. And so I think at the end of the day, when we're talking to our pregnant moms about this, the absolute risk is very, very low. And we already know that the risk of untreated mood disorders and depression is not benign. And so the recommendations that are coming from our obstetric colleagues right now and from the various professional bodies is that for moms who truly have depression and anxiety, that they are treated and that the risk to the baby of antenatal exposure to SSRIs is likely quite low. If we then talk about what happens postnatally, we will see some impact on these babies of exposure to SSRI. So they can develop poor neonatal adaptation syndrome. And so this is neonatal withdrawal. It will occur in about 30% of exposed newborns. And the babies can experience poor muscle tone, jitteriness, irritability, feeding difficulties, sleep disturbance, and hypoglycemia. And it can be quite dramatic. I'm discharging a baby home today whose mom is on an SSRI, and the baby has really significant jitteriness that's very, very noticeable that we anticipate is because the baby has been exposed to this medication and that's impacting it. The other one that we worry about, so that tends to settle and you just need to follow the baby's feeding. The other one we worry about though is persistent pulmonary hypertension of the newborn. And so what can happen is the higher serotonin levels that result from SSRIs can lead to vasoconstriction and smooth muscle proliferation in the pulmonary vasculature. And so what happens after the babies are born is that the pulmonary vascular resistance doesn't fall post-delivery. And so you don't get sort of creation or normal newborn physiology right away. You end up getting shunting where blood is bypassing the lungs still and is now deoxygenated. And so these babies can be quite hypoxic and quite unwell at birth. It can range from sort of mild respiratory distress to severe respiratory failure, like the case that I presented to you. The absolute risk is low. So you're talking about 3 to 4 per 1,000 live births. But the odds ratio is about double that of the normal population. So normal newborns have a risk of PPHN, but it's about double the risk of normal newborns. I was surprised by these numbers to see how infrequent it is reported, because we've seen lots of difficulty with transitions with newborns. We get called quite regularly to deliveries where Moms are on SSRIs, and their babies have had some difficulty with transition. So if you talk to a pediatrician, none of us are surprised by this. I was on call Wednesday and got called to a code pink, which was exactly that, a baby whose mom was on SSRIs, and then mom had another risk factor, was under general anesthetic, and the baby came out and didn't breathe. And typically these babies transition through, and once they've opened up and their pulmonary vascular resistance has dropped, they do well. But it was certainly something that we see. So the question then becomes, so what? What do we do about this? So the recommendation is that we do not wean the antidepressants antenatally. If moms are really needing this and they need to stay on this medication and have their mood disorder treated. Early on in the literature, there'd been some suggestion that perhaps babies whose moms were on fluoxetine or paroxetine needed an antenatal echo. They do not need an antenatal echo any longer. There's no evidence to support cardiac abnormalities, and so they don't need an echo. As is recommended by NRP, there needs to be one NRP trained person at every delivery, but that's the case for every newborn delivery, so that's not a change in practice. Babies should be screened for congenital heart disease prior to discharge, but this is something that's now being done provincially. It's done on all newborns, so that is also not a change in practice. And I would say to you, just to anticipate that these babies may need some support, particularly with ventilation post-delivery. They should be observed in hospital for 24 to 48 hours for postnatal neonatal adaptation syndrome. Some places use the Finnegan score, which I'll talk about later. We don't recommend that because we don't treat these babies with anything other than conservative measures like swaddling and feeding support. And importantly, that there's no contraindication to breastfeeding. So if moms are on SSRIs, they're allowed to continue breastfeeding. We really encourage breastfeeding. I'm going to pause there for a question before we're going to move on now to marijuana. And I just wondered if anybody has any questions about this before I move on.
Hi, Dr. Gordon. Can you hear me okay?
Sure can.
Hi, it's Brad here. I'm a resident at Medical Associates in Parry Sound. So my question, I guess, is what are the complications that go along with pulmonary hypertension? Like, for example, if kids are going into shock, like, I guess, what is the epidemiology around the complications of, say, like anoxic brain injury, hearing impairments? Do we need to worry about stuff like that? And does that occur frequently enough that we should be telling parents that, you know, if, you know, you're a mom and you're on an SSRI and pulmonary hypertension is a risk for these babies, should we be counseling around the potential risks of going into pulmonary hypertension, even though that's something we can treat supportively?
Yeah, that's a great question, Brad. So first of all, I want you to remember the numbers that it's really, really uncommon, right? So we're talking about 3.5 per 1,000. And so it is far, far more likely that the babies who are born who are not going to get pulmonary hypertension. The second issue is that there's a real range. And so the case that I presented is really on the extreme end. The vast majority of babies that we see with pulmonary hypertension or difficulty with transition post-delivery, it's very short-lived. You can really tell once their pulmonary pressures have dropped, they do fine. So for example, the delivery I went to on Wednesday, when this baby came out and didn't breathe, we bagged the baby for about 2 minutes and then the baby was fine. So I would say to you that the risk of things like long-term developmental delays, hearing impairment, that kind of stuff is pretty negligible. And I would not be telling these poor moms who are already struggling with anxiety or depression about that risk, because I think your risk is way, 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 way less than 0.1%. It really wouldn't be any greater than the general population. And we don't follow these babies developmentally any differently than a normal newborn, unless they're on the really, really severe end. So a term baby that's ended up intubated and we've worried about severe PPHN that ended up transferring to the tertiary level center, those babies may get followed for developmental issues, but then that would be a conversation that we would have postnatally. And so the answer to your question is, I think it's not unreasonable to mention, the way that I would phrase it, I would mention to moms that when they're on this medication, that sometimes the babies will come out and need some breathing support, but it's very uncommon, and that we don't recommend that they stop their medication because the risk of untreated depression and anxiety is greater for the babies. and not make it any more complicated than that. Because I think the other risk is that if we start talking to moms and make the risk seem large, that many of them will come off their medication, which can also be harmful in terms of neonatal outcomes, maternal-child interactions, and long-term development. Does that answer your question?
Yeah, thank you very much for that detailed answer. Yeah, I guess the long and the short of it is don't stir up more anxieties than we need to for moms who are going through pregnancy.
Yeah.
And I guess my last question for around this case is, and maybe one of the Emerge docs might be able to speak a little bit better to this, but so my understanding of pulmonary hypertension in adults at least is that there needs to be some caution with intubation because it can cause right-sided heart failure. Do we need to worry about that in kids? No. Okay, thanks.
No, it's totally different. In fact, what they need is often they need intubation and ventilation and then sedation because they need that oxygenation to help drop their pulmonary pressures. So there would not be, it's different physiology because you're out. I don't know anything about grown-ups scare me, but my understanding would be the adults would have had pulmonary hypertension for long term. And so they have had time for, like, they're going to have adaptation in the cardiac and pulmonary system that's going to be released, that's going to be sort of long-standing because of their underlying pathology that's causing the pulmonary hypertension. This is different. This is a newborn who has pulmonary hypertension because they still have, it's the other way to think about it is persistent fetal circulation. So it's the way that circulation is supposed to happen inside. It's just they haven't switched over to external circulation, and we need to do things to help them switch over. So good ventilation, if intubation if they need it, 100% oxygen, and sometimes sedation. And the tertiary level centers will help guide you through that in the very unlikely event that you have a baby with PPHN.
Thank you very much.
Hi, Michelle, it's Dave Clark here. So just to follow up on this. So you're saying, so PPHN is really a diagnosis of exclusion though? Like there is no simple test that says, oh, this is PPHN. It's not. Okay.
These are going to be the ones where you are like desperate for the transport team to get there because it's going to be like, we know that it's that from circumstance, right? So you have a cold section of a baby who was, or like a section of a baby who's in trouble, no labor, mom's on an SSRI, baby never breathed, baby's now satting 50% and 100% oxygen. Your differential is either PPHN or they have an underlying congenital heart disease, and you're not going to know the difference. So those are the differentials. They're either like, they're not oxygenating because there's shunting of blood, of oxygenated and deoxygenated blood that's mixing in the heart. And so you don't know if you've got PPHN or if you've got an underlying complex cyanotic congenital heart lesion. Those are your two differentials. And so, which is beyond the scope for this talk. We can do that talk next year if you want. But you're not going to know for sure. And so these babies need tertiary level care, and most of them end up with echoes.
Thank you very much, Dr. Gordon.
Tim, I see you've got your hand up.
Yes, two things. First thing, Michelle, is you don't have to worry about adult medicine. You just have to treat them as big children. That's what I always recommend. And then the other thing was, and I think you sort of alluded to the answer, but just more of the impact if it was the case. So observing in hospital for 24 to 48 hours. I mean, if I think of two of my three that I was involved with, of my own family, 24 hours would be, with a midwife, particularly for two of the three, would be a particularly long time, considering how quickly we were discharged. And obviously that's not what you're recommending, but I would see that being a huge impact on discharge, particularly with our midwifery colleagues as well.
Right. So that's why we're talking about it this morning, right? So these babies, we talk about this really rapid discharge with, within a couple of hours of midwifery clients who are at home. Those are normal newborns. I mean, you've got a mom who's on a medication, they're no longer, they're kind of out of that bucket of normal newborns. And we kind of go back and forth with our midwifery colleagues here about this as well. The risk that you have is not so much PPHN because you're either going to see it or not see it at delivery. It's more the risk that we talked about, the withdrawal symptoms. So really jittery, hypoglycemia, poor feeding, just not doing well. And sometimes you miss how much these babies are struggling if they go home too soon. So again, I think there's room for judgment. The recommendations from the various obstetrical bodies and neonatal bodies are really that these babies do get observed for 24 to 48 hours, which is a difference in practice, particularly for midwifery colleagues. I think if you've got a baby who's clearly doing well, not jittery, feeding great, no hypoglycemia, going to be seen within 12 hours, there may be some room for judgment, and otherwise these babies just stay in. Our midwives here actually tell their moms on SSRIs that they stay in for 24 hours. Okay, Kathy, am I missing any other questions? No, okay,
No.
we'll keep going. We're going to go for the next substances. Okay, so this is now next case is a 25-year-old G1P0. Poor Brad, now that I know there's a resident here, we're going to pick on him the whole time. Normal pregnancy, A positive, GBS negative, serology is protective, ultrasounds are normal. So pretty normal pregnancy. Mom has mild anxiety, and she says that she smokes marijuana daily, 1 to 2 joints to help her sleep. And she's now in her first trimester. So she's now come to you for her care. And the question is, what are you going to tell her about marijuana and pregnancy? Anybody want to jump in? How many people have seen moms like this in the last couple of weeks if you do obstetrical care?
It's perfectly fine, Michelle, like it is for everything, for anxiety, sleep, your high blood pressure, everything. We recommend it for everything, I understand
It's
now.
a miracle. Yeah.
Yep, it is. It's the big man was holding it back for many years, and now we're allowed to use it.
Yeah. So we have this conversation like all the time, which is why I'm talking about it. Because if you guys do any kind of primary care for pregnant moms and newborns, you're going to have this conversation. So hopefully I'm arming you with some information. So what are we going to talk about marijuana pregnancy? Well, you're about to find out. So we're first going to talk about how common this is. So in a 2015 survey, cannabis use in pregnancy is really, really common. So this is the Canadian Tobacco and Alcohol Survey. So 5 to 15% of pregnant women used in the last month. About 13% of women had used in the last year, and 45% in their lifetime. It's more common in young adults. So 30% of young adults have used in the last year, 10% of all females. If you're urban, young, or socioeconomically disadvantaged, you're more likely to use cannabis. So 50 to 28% of those women, and 5% of breastfeeding mothers use marijuana. In the UK, they did a study where they screened all newborns. They did urine tests on all newborns and found that 13% of newborns had THC in their systems, even if the moms had not reported using marijuana. And if you look at what happens to these moms, 45% of moms who use marijuana continue throughout their pregnancy. However, what we do makes a difference. And so if we counsel moms to stop marijuana during pregnancy as a result of the potential risks to their newborn, 78% of them do stop. And so the information that we provide moms can actually make a big difference in terms of what happens to the newborn. So that's my little call to action for you. So when you have cannabis in pregnancy, this again is a bit of a hot mess, and the data is very, very variable. So there's a systematic review done in 2016 that showed that moms, if an infant was born to a mom who used cannabis, there's increased risk of decreased birth weight, preterm delivery, and NICU admission. There's another study also done in 2016 that said there was no increased risk of preterm delivery unless they smoked both tobacco and marijuana. No risk of SGA or NICU stay. However, they tended to have lower mean birth weight and lower APGAR. So there's a bit of conflicting data. There's another one that was a population-based cohort study where the information is more consistent. And what they found was that if moms are using both marijuana and tobacco, which many of them, if not most of them are, that combined marijuana and tobacco use tends to increase the risk of maternal asthma and preeclampsia, that those babies do have an increased risk of preterm birth, which has its own developmental issues. The babies tend to be smaller, and they tend to have a smaller head circumference, all of which is going to result in more adverse neonatal outcomes and developmental outcomes. Postnatally, these babies, we also see impact with these babies. So these babies tend to have altered arousal patterns, and so can have difficulties with sort of regulation and excitability. They often have increased tremors and really exaggerated startle reflexes. They're much more likely to have poor feeding, and weight gain is often an issue. And then interestingly, there's 2 longitudinal studies. So there's the Ottawa prenatal prospective study, and the maternal health practices and child development study that looked at what's the longer term developmental impact of children who are exposed to marijuana antenatally. And what they found was there were differences. and that these differences were showed a dose response. So the women who you had higher cannabis use had children who demonstrated more difficulties with development. There's also functional MRI studies that show changes in neural activity with working memory. So there's perhaps some biologic plausibility. And so what they saw was at age 4, children who were exposed antenatally to cannabis had lower verbal reasoning and memory. At age 6, that there were deficits in language comprehension, visual and perceptual functioning, and any reading tasks that required sustained attention. At age 12, they had deficits in executive functioning, impulse control, and problem solving. And at age 14, they had lower global achievement and lower scores in reading, spelling, and math. And so if I was going to summarize this for a mom, you're not going to go through all this in detail, but what I would say to her is that there is some evidence that babies born to moms who are using cannabis antenatally do have some evidence of delays and difficulties in their development that seems to be directly related to their marijuana use antenatally, and seems to be have a dose response curve. So the more marijuana that's used, the more difficulty that they have. Obviously, these are really, really poor quality studies. It's hard to control for all the variables in terms of genetics, the parental history, and environmental factors. And so it's really hard to tease out how much of this is marijuana exposure and how much of this are other factors that may be involved. But certainly there's no evidence that would strongly convince me that marijuana is safe, and perhaps some evidence that would suggest that there is some evidence that babies are more likely to be small and have and be born early, and some evidence that developmentally there's longer term consequences. There's also some issues with behavior for these children who are exposed to marijuana antenatally. So there's a higher incidence of behavior problems at age 6 to 9. They're more likely to have depression and externalizing behaviors. These are now the children, and the children are more likely to have substance use. But again, these are really, really poor quality studies. So these rely on self-report. Often women are using other substances, and you cannot control for social demographic variables or for genetics or family history. And so take this with a bit of a grain of salt. The next big question that we get is, what do we do about breastfeeding when moms are using marijuana? When I started in practice, the information that we had at the time, which I think is still perhaps accurate, is that marijuana is lipophilic. So we know that, and it can be concentrated in breast milk in very heavy users. And so there's been some studies that show that moms can, that breast milk can have up to 10 times to the concentration of marijuana in the breast milk as compared to the mom's serum if they're really, really heavy users. And so the baby's getting a significant increase in dose. There's one study that showed a 14-point decrease in motor score at a year of age for babies who are exposed to marijuana through the breast milk. Again, it's really, really difficult to control these studies. And at the end of the day, looking at larger cohort studies, it's really hard to tease out, and there's not any clear harm demonstrated from breastfeeding and cannabis alone. And so practically speaking, we now have shifted entirely. We used to tell moms they weren't allowed to breastfeed if they were using cannabis, because cannabis was going to stay in their breast milk for 4 weeks. And so they needed to pump and dump for 4 weeks, which obviously meant that none of our patients on cannabis ended up breastfeeding. We now know that breastfeeding is really important in terms of bonding, growth, nutrition, development, immune function. You know, I can keep going and keep going and keep going. And so now it is felt that the potential harm of cannabis in breast milk is outweighed by the potential benefit. And so even for our heavy users, we're not counseling them to not breastfeed. It's really a risk reduction approach. However, we do talk to all of our moms who are using marijuana and recommend that they stop or reduce as much as possible to avoid exposure through the breast milk, and explain to them that marijuana can get concentrated in the breast milk because it is lipophilic or attached to fatty tissue. So what do? The recommendation is that we screen all moms for substance use at all prenatal visits. There's a clear recommendation that pregnant women should abstain from marijuana use, and that is a consistent recommendation from the SOGC, from the WHO, from the American College of Obstetrics and Gynecology, and from the American Academy of Pediatrics. Breastfeeding women also should abstain from using marijuana. However, the WHO has come out with a statement that said that mothers with substance use disorder should be still encouraged to breastfeed unless the risks clearly outweigh the benefit. And so that's the approach that we're taking, we're taking right now. And for anybody who's interested, we've created a one-page handout for our moms that goes through the risks of marijuana and breastfeeding that we give to all of our moms who tell us that they're using marijuana, so that they can make an informed choice about what they're doing. I'm going to pause there before we move on to opiates. Any questions?
Hi, Dr. Gordon. Sorry, this is Brad here again. This is a question that has nothing to do with this talk, but my brain is evading me here. For women or for moms with substance use disorders that are IV drug use based, and there's a potential risk of HIV, and for those women, are we worried about them breastfeeding? I guess the if I was counseling it, it would be, you know, treat the substance use disorder, encourage against IV drug use, continue the breastfeeding, and screen for those kinds of illnesses. I guess that's probably the right approach, eh?
Yeah, so that one gets really complicated. We'll talk about that a little bit with the next case. And so that's really different. If we had a mom who's a known IV drug user, you want to make sure she's got up-to-date serology. That some of those moms, if they've continued to use IV drugs kind of after their last test, infectious disease is often telling us to screen the babies at birth for HIV and to put them on HIV PEP. And then obviously you're testing for hepatitis and giving them hepatitis immunoglobulin and that kind of stuff as well. And then it's really, these are the moms where you're looking to see, like, what is the risk to baby? You know, if I've got a mom who's still actively using, you know, cocaine, for example, you're going to get some of that through the breast milk. There's potential developmental harm for babies. And most of the time we're not supporting moms to continue breastfeeding. There's also concern about what's their capacity around parenting and safety and that kind of stuff. So those are really, and each case is a little bit different. And so if you have a case that's complicated, I think first of all, if you've got a mom who's an IV drug user, it's likely that baby is coming to us anyway. And if not, you're going to want to get some advice from either us or infectious disease at SickKids just on how to navigate through some of those risk factors, but it's much broader than just breastfeeding. Generally the amount of substance that goes into the breast milk is relatively lower, with the exception of marijuana. But even with marijuana, we don't recommend that they stop. And the only medication that is 100% contraindication to breastfeeding, there's only one, so it's easy to remember, is lithium. And so otherwise, lithium and chemotherapy. So if moms are on lithium or chemotherapy, then they're not breastfeeding, but otherwise it's really a harm reduction based approach. And much of the time it's felt that breastfeeding is you know, if moms who are able to breastfeed are going to be in a parenting role and are able to breastfeed, then that breastfeeding is more important than the value of the breastfeeding outweighs the potential risk. I hope that answers that question. That's a big topic that would sort of be a bit more than what I can do in a few seconds.
Thank you very much.
Okay, I see Winifred has her hand up.
It's actually Ken.
Oh, hi, Ken.
It's more of an obstetrics question, but we seem to be seeing a lot of young people, and especially women, with vomiting coming to emerge, or this sort of extreme vomiting. And we end up just assuming that it's cannabis because we can't find any other explanation. But pregnancy is associated with hyperemesis, and I just wondered what the experience is with that.
Yeah, so I think we're talking a little bit about apples and oranges. And so I'm not an obstetrical care provider, and I don't do grown-ups, they scare me. So certainly vomiting in pregnancy is quite common and is separate. However, I do see young adolescents. You know, the kids that I see tend to be the young, sort of 14, 15, typically it's 14, 15, 16-year-old girls who usually have an underlying diagnosis of anxiety and are using marijuana very heavily. And those kids can absolutely get hyperemesis from marijuana use. And it is difficult to treat, persistent, significant, and tends to last for a long time. It is not necessarily there's not necessarily a clear dose response curve. And so the women that you're talking about, I've seen them as well. And we definitely see it in kids who, and I guess you'll see them in adults who are using marijuana quite heavily. Sometimes they mistakenly take marijuana to try and treat it, and it ends up being a really vicious cycle. My advice to them is stop using marijuana, and then really working on renourishment and rehydration and that kind of stuff. Okay, I'm going to move on to our last sort of topic. So this is a 27-year-old that we just saw a few weeks ago, G5P1 L1T1 SA3 mum. So this is, I think, the case that Brad was alluding to a little bit, or something similar. So this mom has a history of recreational drug use and is now on the methadone program. Unfortunately, she'd been admitted to another hospital a week prior with a fentanyl overdose, and then used fentanyl 2 hours prior to presentation in labor. She was A positive, GBS negative, serology unknown, ultrasounds were normal, and she had tested positive for gonorrhea and chlamydia twice in pregnancy with no test of cure. So the baby was presented in spontaneous labor. She had thick meconium present. The baby cried at delivery, but had very poor tone and color. Ended up requiring PPV with up to 80% oxygen. Then it was changed to CPAP and transferred to the NICU. I was going to bug you guys about this as well, but we've talked about that a little bit with the question that Brad had asked. So I'm going to move on just in the interest of time. And in terms of what we need to think about, these were some of the things that Dr. Newman thought about. This is her patient. And so she needed to consider treatment. So this baby received treatment for chlamydia and gonorrhea, as well as sepsis, and then got HIV prophylaxis because we didn't know that this mom had been cured of gonorrhea and chlamydia, and she'd continued to use intravenous drug use without an updated serology. The baby needed support. And importantly, because this mom was using methadone and on opiates, the baby was not to be given Narcan because it would precipitate significant withdrawal, which can include seizures. The baby obviously required NAS monitoring. And then the question that is socially, what access does mom get to the baby? What's her parenting capacity going to be? And what supports does she need? So it's also so it's both medically quite complicated and psychosocially quite complicated. So for this baby, the baby ended up having severe neonatal abstinence syndrome, required morphine, clonidine, and phenobarb, which is unusual for us for babies to need all of this, and was end up sending home with a CAS and an alternate caregiver on phenobarb with neonatal follow-up with Dr. Newman. So if we talk about opiates, Canada is the world's second largest per capita consumer of opiates. This is based on the 2014 National Survey on Drug Use and Health. And in Canada, we have the dubious honor of Ontario being the highest rate of narcotic use in Canada. 5% of pregnant women will report illicit drug use in the past 30 days. There's a smaller proportion, 0.2%, that use heroin and 1% that have non-medicinal use of prescription opiates. Maternal opiate use, either prescribed or illicit during pregnancy, is associated with negative pregnancy and neonatal outcomes, including premature delivery, IUGR, so growth restriction, low birth weight, and neonatal abstinence syndrome. And we do opiate substitution with methadone and other substances because it seems to lessen the antenatal exposure to other illicit drugs and improve prenatal care. Sorry, I'm just trying to get unfrozen. So it seems to improve access to prenatal care, access to counseling and educational support. So all of those things seem to be protective of our babies. If we look at what are the long-term impacts of opiate exposures developmentally, we tend to see cognitive deficits, poor verbal performance, impairment in short-term memory and executive function, and school performance deficits. And if you look at these, the longer term impact of behavioral issues, that these children are twice as likely to have ADHD, conduct disorders, and adjustment disorders. Again, these studies are poorly controlled. It's hard to control for all of the variables. They're more likely to be aggressive and have anxiety disorders. They're increased risk for hospitalization, for maltreatment. These are the children are increased risk of hospitalization for maltreatment, trauma, and behavior problems. And the mortality rates are higher. And in one study in the US, the mortality rates were up to 4 times higher in New York for the babies that have been exposed to opiates antenatally. So we talk about what is neonatal abstinence syndrome. It's a constellation of signs and symptoms of the newborn that are due to withdrawal from in utero drug exposure. And we tend to see it across three main areas. So neurologic, you get a high-pitched cry, exaggerated startles, and increased tone. They tend to have GI, so poor feeding, vomiting, loose stools, and failure to thrive, and then respiratory symptoms. Regular maternal drug use in the last 2 weeks prior to birth is a risk factor to NAS. And somewhere between 50 to 75% of infants will require treatment for withdrawal. So for any of you guys who are seeing, I don't know if anybody's doing a methadone clinic up there, occasionally we have some difficulty because sometimes the methadone doctors are telling moms that they're not going to, their baby, if they're on methadone, their babies are not going to have withdrawal. That's not true. 50 to 75% of infants will have withdrawal, even when moms are on methadone. And typically we tend to see symptoms within the first 72 hours, but can be as long as 5 to 7 days, particularly with the longer acting opiates. The dose of methadone is not predictive of neonatal abstinence syndrome, which is something I find a bit mind-blowing, but it's not predictive. You can't really tell which babies are going to get NAS and which babies are not. However, polysubstance use is. So if moms are on methadone and also using opiates or marijuana and cigarette smoke and other things, that is more predictive of withdrawal. And preterm infants do not appear to be as affected as term infants. If you look at how common this is, in Canada, it's about 3.8 per 1,000 births. And in Ontario, we tend to be above the national averages. It's increasing. So in between 2002 and 2003, it was 0.9 per 1,000 births. And about a decade later, it was 5 per 1,000 births. Now in 2015, 2016, CIHI reported that about 0.5% of all infants have NAS. So in Canada, that's about 1,850 babies a year. And their average length of stay is 15 days. So it's a huge impact on our healthcare system. And so we know that these babies tend to have prolonged stay in hospital for specialized care, that they tend to utilize level 2 NICU resources quite significantly. And we've already talked about the potential developmental and psychological problems long-term. So the Provincial Council on Maternal Child Health put out some guidelines in 2016, going through how we manage moms who are using opiates antenatally. So they recommended that all women of childbearing age be screened for illicit substance use because it can lead to early identification. It helps normalize the conversation. It results in comprehensive screening, so not just opiates. So start having these conversations with your young women of childbearing age, and I would say even your teenagers, because it normalizes the fact that it's something that you can talk about. Women at risk of opiate use disorder should be educated about the risk of opiate use on their reproductive health, so that we really want to try and avoid unplanned pregnancies because of the potential risk on babies. And so contraceptive counseling for moms who are using opiates antenatally. All pregnant women should be screened for substance use. So during their prenatal visits. That does not mean they all get a urine screen. That's not what I'm saying, but just screening on history. And for pregnant women who are using opiates, they need to be referred to get comprehensive care. So they should have obstetrical care, addictions resources, community care, counseling, and support. And if I can make a little plug for any of your moms who are on opiates antenatally, please also refer them for antenatal consult with pediatrics, because then we can walk them through what the postnatal care looks like. And it's really helpful. It helps things go better. Every pregnant opiate woman using woman should get written material explaining NAS. We're happy to do that when we see them in antenatal consult. And just know that methadone maintenance therapy is a standard of care for opiate use disorders in pregnancy. Not all cases need to be referred to children's aid. So it's really done on a case-by-case parent basis. If you've got a mom who's really doing well, who has been on a methadone program and is stable, who's in a stable social circumstance, those parents do not necessarily need children's aid involved. We have social work see all of them, and we do CIS on a case-by-case basis. Really important that during labor, women should continue to take their daily opiate agonist to avoid withdrawal. And many of our women who've experienced opiate addiction and who are now successfully on the methadone program, sometimes are quite reluctant to get analgesia because they don't want to risk a relapse, but they really, they can receive analgesia in pregnancy, should be encouraged to receive analgesia in pregnancy if they need it, in addition to their daily opiate antagonist. Do not give narcotic antagonists to either mom or baby because it's going to precipitate withdrawal and potentially seizures. It's really helpful for us to have conversations before the baby's born about what postnatal care is going to look like, because it really helps families do well. PCMCH has a sample prenatal care plan that can be used and developed with women. And if anybody's interested, I'm happy to give you access to these to this if you need it. When babies are born, all babies should be screened on antenatal history, and so we should be able to identify which babies are going to be at risk of neonatal abstinence syndrome postnatally. And then a standardized neonatal abstinence scoring tool is recommended. And again, I do not expect that you guys are going to be doing this in your center. If you've got a baby who needs to be monitored for NAS, that's something we're happy to do. They need to be scored for 72 hours for short acting or for 5 days for long acting, and scored every 2 to 4 hours. And we're really trying to promote mother-baby dyad care. The standard scoring tool has traditionally been the Finnegan scoring tool, which I'm showing you here. It was developed in the 70s, and it's the sort of standardized tool. However, the downsides of this tool is that it can vary based on the score. So there's a lot of sort of interpretation, and it tends to be very staff focused. So it's really things that the staff are noticing. It's not a functional score. It's not sort of looking at how is the baby actually doing, how's mom actually doing, how's feeding actually going. It's really looking at, are there tremors and how's the baby crying, and other things that are a bit more subjective. And so we really get a wide swing when we're scoring babies with the Finnegan score around whether or not they're needing treatment and sort of what happens with them. In terms of what we do for newborns treatment-wise, non-pharmacologically, we really need to modify their environment. So these tend to be pretty irritable babies, and so we need to reduce their sensory stimuli, limit visitors, minimize lighting, and reduce noise, and look at soothing behavior, so positional support, kangaroo care, swaddling, and things like that. Breastfeeding is recommended for all. It helps reduce withdrawal. Actually, they get a little bit of methadone through their breast milk, and it really helps the babies. And then preventative skin care to reduce the breakdown that we tend to see in the diaper dermatitis. Pharmacologic treatment is recommended for all babies who fail non-pharmacologic treatment. First line is morphine. And then if babies like the one I presented to you initially who are difficult to control may end up requiring additional medications like clonidine or phenobarb. And that, again, that would be something that we would be doing, but just for your information, you may have families who end up being on this. This is the new thing. So the Finnegan score I showed you was developed in the 70s, and the focus was really on decreasing baby scores rather than looking at how baby is functioning. So Eat, Sleep, Console really looks at how the baby is functioning. It was started in the mid-2010s, and it looked at how is the baby doing, really maximizing some of those non-pharmacologic methods I've talked to you about, maximizing parental involvement, and then using as needed morphine. And the studies have showed that sort of old school, the babies who experienced abstinence were in hospital for about 17 days. And with Eat, Sleep, Console, we can get that length of stay down by almost 5 days, which makes a huge difference for families and makes a huge difference for our level 2 resources. And the way that this works is much, much less dependent on caregiver scoring. So it's pretty straightforward. So is the baby feeding? And so adequate eating is the baby eating sort of 8 to 12 times a day? Poor eating is if they're unable to coordinate feeds within 10 minutes of showing hunger cues or can't sustain feeds for 10 minutes. Sleeping is the baby sleeping? And so normal sleep for age versus sleeping for less than an hour. And consoling is the baby able to be consoled within 10 minutes? And so you start by talking to them and then helping them put their hand to their mouth, and then doing gentle movements, picking up the baby, offering a pacifier, and do those things work within 10 minutes or not? And it's yes or no for each of these categories. And so it's a much, much more straightforward Eat, Sleep, Console score. And the possible scores are 0, 1, 2, or 3. If the baby's getting a 0, there's no intervention. If it's a 1 or a 2, typically the team is meeting together and looking to say, are there any of these non-pharmacologic things that we can do? Is there anything else going on that may be increasing these babies' scores? And then if they are scoring 3 or 4, then the baby is getting all the non-pharmacologic as well as medication. So we'll be implementing this in our NICU soon here, with the hope that we're going to really maximize parental involvement, improve their experience, and decrease our length of stay. So if we look at discharge planning, all babies need to be monitored. So 72 hours for short-acting opiates and 5 days for the long-acting opiate antagonists. They really require support from primary care, and we need to be looking at discharge planning that's comprehensive and well coordinated with CAS on a case-by-case basis. Any baby who's been treated for neonatal abstinence syndrome will have ongoing assessments in our neonatal follow-up clinic. And so we're going to be helping with that part. And now I'm going to just try and give you some really practical tips. So antenatally, a good history screening for substance use disorders, reassessing need for meds. Just remember that there's no clear evidence for teratogenicity with SSRIs. So please be reassuring to your moms who are on there. Just remember that there is an impact of untreated depression. Please counsel moms who are on marijuana to stop, because our counseling works. And if a mom's on opiates, please refer them to a program to get them on the longer acting opiates, and they get comprehensive care, and then send them down for antenatal consults for your moms on methadone, and link them with appropriate community services. Intrapartum, at least one NRP trained person for baby at each delivery. Our moms whose babies are on opiates tend not to run into trouble right away. And so there's not a contraindication for those babies delivering in a level 1 center. Just remember not to use Narcan for babies of moms on opiates, and anticipate PPHN for babies whose moms are on SSRIs. Postpartum, these babies are all going to be careful monitoring. So all 3 of the substances I've told you about, marijuana, SSRIs, and opiates, all cause difficulties with feeding. And so that's going to need to be monitored very carefully. Babies with NAS are going to need to be monitored quite closely, and then a case-by-case consideration of community service. Post-discharge, these babies, particularly our NAS babies, require very close follow-up, and that's where our partnership with you guys is really key, because we'll be discharging these babies home and try to get them followed up within 24 to 48 hours. And that's it. I'm happy to answer any other questions about this or anything else anybody else wants to talk about. And hello to everybody.
Hi, Dr. Gordon, it's Brad here. We actually have a question in the room, but I'll just be 1 second. I'm just trying to get a hold of the question here, and then I'll voice it. 1 moment.
Tom, I see your hand is up. Do you want to ask the question while Brad's collecting his question?
Poor Brad, he's dedicated as the resident to be the question asker from the room of participants.
I think that's very appropriate, right? Torturing residents just a little bit. Brad, you're welcome to come to my peds clinics when I'm up in Prairie Sound if you like.
She wants to.
Yeah. Thank you. I should take you up on that offer. I'll see if I can coordinate it with the clinic here, because there's lots I could learn from you. So I think the question in the room is on one of your last slides. It says close follow-up or follow-up with the primary care family physician. It sounds like in the setting post, I guess, NAS discharge. Could you further elaborate on, I guess, on what the finer details of that is? How regularly should we be following up? How soon should we be following up? Would we expect to see instruction in the discharge summary from the pediatrician on the type of follow-up and that sort of stuff?
Yeah, perfect. That's a great question. So typically these babies, remember the risk that for these babies who've been exposed to opiates antenatally, both with or without treatment for neonatal abstinence, is going to be they're particularly at risk of poor feeding. And so I'm probably actually even more worried about the babies who don't need treatment, because those babies we're sending home quite quickly. Now, if they're on methadone, they're being seen for 5 days. And so we should have a feeding well established by then. But those families, we're typically asking them to see their primary care provider within 24 to 48 hours. So trying to get a pretty early discharge follow-up so that they can be seen. And what you're really looking for initially is how are these babies feeding and are they gaining weight? Once you know that they're gaining weight, then you can sort of lengthen those visits out, and it's much more typical care. Secondarily, it's just developmental screening. That would be what you're doing already with your nipissing. Any babies that's received treatment already is going to be coming down to our neonatal follow-up clinic where they get seen. We see them at 6 weeks, and then we see them at 4, 8, 12, 18, and 24 months. And so we're already doing pretty involved developmental screening for babies who've had treatment for NAS. And then, so it's really, those are the kinds of things. So it's not anything particularly specialized. It's just recognizing that these may be vulnerable babies and making sure that they're connected with primary care services. Again, once it's clear that they're gaining weight well, it'd be much more to your typical follow-up. And so, I'd see them in a couple of days, and then probably at 7 to 10 days, and then, probably at a month, and then at 2 months, just to make sure that they're gaining weight and thriving and following up, and that mom's doing okay as well, because she'll need to be screened for postpartum depression and mood disorders, and how's she doing, and does she have the support that she needs to make sure that she's doing well. If there's anything more like different than that, we will send you detailed instructions in our discharge summaries. And the ones that are the really involved, the ones that require like follow-up serology, and like the really complicated ones we're seeing, and we're going to keep seeing. We see for 2 years through neonatal follow-up. We don't do the primary care, but we will in the discharge letter, you'll get instructions about what we're going to be doing and what sort of support we need from primary care.
Thanks, Dr. Gordon. That clarifies it. So I guess to kind of summarize that, it's almost like taking the eat, sleep, console sort of template, so to speak, to the primary care office. Is baby eating? If they're eating, they should be gaining weight. And then if they're still, consoling well and sleeping well, it's kind of like baby's basic functions are more or less working, and that sort of thing.
Exactly.
Okay.
And then you guys have the benefit, because you're also adult care providers, is also, I would sort of check and make sure that functionally the baby's doing okay. And then also just that screening with mom, and make sure that that she's also doing okay and supported.
Well, thank you very much. I don't have any other questions. I don't know if there's any other questions in our room, but I just want to say thank you. This was great, and I really enjoyed the presentation.
Thank you. And I appreciate everybody asking questions, because it's these Zoom ones are fun, but it also feels a bit like a talking head in a box. So I appreciate all the interactivity. I'm happy to come back anytime. And if you guys send me suggestions about what it is you guys would like me to talk about, I'm happy. It's actually super helpful, because this is what you guys asked for last year. And so then I gave this rounds to you guys, and I'm giving it to Huntsville and to Aurelia as well. So it's great. You guys can keep generating what you want to hear about. I will give you guys back your time, and have a really wonderful afternoon, everybody.
Thank you very much,
Thanks
Michelle.
so much.
Thanks,
Bye.
Kathy. Have a good day.
You too.
Thanks, Kathy. Do you need anything else from me?
No, I'm good.
Okay.
I'll stop recording.